Okay, let's dive right into this explainer. We're going to see exactly how surgeons use symptoms, imaging, and pure anatomy to solve some of the most complex physiological puzzles in the human body. We're looking way past the surface of a standard checkup today. We're going deep into the operating room, where diagnosing an issue requires a profound understanding of hidden biological pathways and incredibly strict clinical thresholds.
Imagine for a second facing some truly baffling symptoms. Like, say, a patient comes in with what we call a jelly belly. Or maybe moving their leg triggers this agonizing abdominal pain. A simple blood test just isn't going to give you the answer here. You really have to understand the body's internal architecture. You know, how fluid flows, where pressure builds up, and how entirely different compartments silently communicate with one another.
Section 1. The lower GI tract, from polyps to twists.
So picture this, a pretty terrifying scenario for any parent, right? A 13-year-old child comes in with painless, bright red bleeding during a bowel movement. When the surgeon performs an exam, they find a single, smooth, bright red, glistening mass protruding from the tissue. So what exactly are we looking at here?
Well, here's the good news. In this specific scenario, a solitary, smooth mass is almost always a benign juvenile polyp. It's got virtually zero malignant potential. Some folks affectionately call it a cherry tumor because of how it looks, but it's really just a tissue malformation filled with mucus. It's completely non-neoplastic, meaning parents can breathe a massive sigh of relief. It is absolutely not cancer.
But there's a terrifying exception to that rule. While finding one polyp is a relief, finding multiple, that completely flips the diagnosis. We still remove solitary polyps to stop the bleeding and prevent the bowel from structurally telescoping on itself, a dangerous condition called intussusception. But if a surgeon scopes the patient and finds more than 5 to 10 of these polyps scattered around, we're now looking at juvenile polyposis syndrome. It's an autosomal dominant condition linked to specific SMAD4 or BMPR1A mutations, and it carries a very real, significant lifetime risk of colon cancer.
And speaking of cancer risk, comparing these specific structures shows us exactly why a sessile villus adenoma triggers immediate loud alarm bells for a surgeon treating adults. Not all polyps are created equal. If you find a pure tubular adenoma, one that looks like a little mushroom on a stalk, the baseline malignant potential is pretty low. But if you see a sessile villus adenoma, that's a broad, flat growth with these long finger-like papillary projections. And if it measures over 2 centimeters, it carries a staggering 40% absolute risk of containing invasive focal adenocarcinoma. The physical structure literally dictates the danger level.
Now, if we look at appendiceal carcinoid tumors, the strict surgical thresholds we use are absolutely fascinating. It's all about size and location. Imagine a patient gets their appendix removed for just standard appendicitis, and the lab accidentally finds a tiny half-centimeter neuroendocrine tumor at the very tip. Should they panic? Actually, no. Under 1 centimeter at the tip means a near zero risk of spreading. The appendectomy they already had is 100% curative. But if that exact same tumor is located at the base of the appendix, right where it meets the colon, or if it grows larger than 2 centimeters anywhere at all, the rules change entirely. The surgeon is mandated to go back in and remove the entire right half of the colon just to clear out those regional lymph nodes.
You know, it's fascinating. The classic flushing and wheezing of carcinoid syndrome, they only happen if the tumor actually manages to bypass the liver's metabolic defenses. It's a brilliant example of systemic anatomy at work. See, these neuroendocrine tumors pump out huge amounts of serotonin. You'd think the patient would have immediate symptoms like flushed skin, bronchial spasms, and diarrhea, but they usually don't. Why? Because the blood from the GI tract routes directly to the liver first, and the liver acts as this massive chemical shield, neutralizing the serotonin instantly. A patient only develops carcinoid syndrome if the tumor spreads into the liver itself, or if it starts in an organ like the lungs, dumping serotonin directly into the systemic bloodstream and bypassing the liver entirely.
All right, let's shift over to the sigmoid colon. This is where an axial twist, also known as a volvulus, becomes a massive emergency. The bowel essentially twists on itself like a wet towel. If it twists just 180 degrees, you get a severe blockage. But the magic, truly terrifying number is 360. At a full 360-degree rotation, the twist completely chokes off the mesenteric blood supply. Within hours, the tissue begins to die, leading to rapid strangulation, gangrene, and catastrophic perforation if it isn't surgically untwisted immediately.
Section 2. Biliary and pancreatic complications. Tracing the postoperative leaks.
Okay, so what happens when dark green bile suddenly floods a surgical drain a few days after a gallbladder removal? Well, we follow an exact procedural pathway to safely map and bypass that iatrogenic ductal injury. First, you have to prove it's actually coming from the biliary system, so we use a HEDA scan, a radioactive tracer processed by the liver.
If you see that tracer spilling out of the ducts on the scan, boom, you've confirmed the leak. But the HEDA scan is kind of blurry. It doesn't show you exactly where the microscopic hole is. For that, you need an ERCP or MRCP to perfectly map the plumbing and eventually place a stent.
Now take a look at this threshold number, 5,000. Amylase, as you might know, is a digestive enzyme made by the pancreas. Normal levels in your blood max out around 140, but if a patient has abdominal surgery and their drain starts leaking clear fluid, we test it. If that fluid registers an amylase level of over 5,000 units per liter, we know without a shadow of a doubt that the main pancreatic duct is actively leaking digestive juices straight into the body cavity.
An ERCP isn't just for diagnosis here. It therapeutically breaks the pressure cycle. It's kind of like a burst pipe in a high-pressure water main. You can't just patch a tiny hole while the pressure is still blasting against it, right? ERCP allows the surgeon to go in, cut the muscular valve at the end of the duct, that's the sphincter of Oddi, and place a stent. This suddenly makes the natural pathway the path of least resistance. The fluid stops pushing against the leak, flows normally into the duodenum, and the hole just heals on its own.
Section 3. Retroperitoneal and peritoneal pathologies. The hidden cavities.
So, understanding how fluid travels between seemingly separate body compartments is absolutely crucial. Imagine a severely ill toxic patient who presents with this bulging, fluctuant mass in their upper thigh. Strangely enough, when the surgeon presses on the thigh mass, it deflates, but a mass deep in their abdomen suddenly swells up. This is called cross-fluctuation. But the abdomen and the thigh are physically separated by a rigid band called the inguinal ligament. So how on earth is the fluid moving back and forth?
The answer to that mystery lies in a continuous anatomical channel centered around the psoas muscle. This muscle attaches to your lower spine, runs deep through your retroperitoneum, slips right underneath that rigid inguinal ligament, and attaches to your femur. If a massive infection starts in the spine, the purulent fluid gets trapped in the sheath of this muscle and uses it like a liquid highway, sliding straight down into the leg. That's what allows the surgeon to physically manipulate the abscess fluid back and forth across the inguinal crease.
And this exact anatomy explains why a patient will naturally, almost instinctively, adopt a defensive, flexed hip posture. They're just trying to relax that muscle. Because the muscle is literally filled with inflammatory fluid, any tension on it is agonizing. If you pull the leg backward into passive hyperextension, which we call the psoas slide, the muscle stretches and the patient will practically jump off the table in pain. Interestingly, what causes this depends on where you live. In endemic regions, it's often a cold abscess caused by spinal TB, known as Pott's disease. In developed areas, it's usually standard pyogenic bacteria like Staph aureus, or a complication from Crohn's disease.
Moving from the retroperitoneum up into the abdominal cavity itself, we run into the truly incredible jelly belly phenomenon, formerly known as pseudomyxoma peritonei. This is driven by ruptured mucinous tumors. If a specific type of appendix tumor ruptures, it spills these mucus-producing cells all over the peritoneal surfaces. These cells then start aggressively producing a thick, gelatinous mucin. Over time, the entire abdomen just fills with massive amounts of this dense jelly, coating all the organs.
Now, to properly prep for the massive cytoreductive surgery and heated chemotherapy this requires, we literally have to map every single gelatinous implant. A standard CT scan is going to look incredibly confusing here, because this jelly has the exact same visual density as normal abdominal fat. So we have to use a fat-suppressed gadolinium MRI. By suppressing the fat, the actual body fat turns dark on the screen, causing the tumor jelly to light up brightly. You get superior soft tissue contrast, and you can clearly see scalloping right along the visceral margins of the liver and spleen where the dense jelly is physically compressing the organs.
Our final section, Section 4, Preventing Post-Splenectomy Sepsis, let's look at our systemic defenses.
Without the spleen's incredible filtering power, a patient is utterly defenseless against 3 specific encapsulated bacteria. See, the spleen clears out these bugs via opsonophagocytosis. It's basically a giant blood filter. When we take it out, the patient develops a terrifying lifetime risk of overwhelming post-splenectomy sepsis, or OPS. Over 50% of these deadly infections are caused by just one bug, Streptococcus pneumonia. Because the natural filter is gone, we have to artificially boost the immune system by strictly immunizing against S. pneumoniae, N. meningitis, and H. influenzae type B.
And this creates a genuinely fascinating surgical timing paradox. If the splenectomy is planned, an elective surgery, we give the vaccines exactly 2 weeks before the operation. Why? Because we want the spleen still in the body to help process the vaccine and generate a massive, optimal antibody response. But
If a patient is in a bad car crash and needs an emergency splenectomy to stop bleeding, we don't vaccinate right away. The physical trauma suppresses the immune system so severely that a vaccine wouldn't even work. In that emergency scenario, vaccines must be deferred until exactly 2 weeks after the surgery, giving the body time to recover enough to actually build that immunity.
From sudden surgical emergencies to deep cellular defenses, the human body is just an absolute masterpiece of precision, which really leaves us wondering, if a simple twist can cut off circulation and removing one organ changes your immune system forever, what other microscopic balances are keeping us alive right now? Today, we've seen how medical detectives decode polyps, trace fluid through hidden muscular highways, and outsmart our own anatomical vulnerabilities. It's an incredible look at the biological machinery that runs silently under our skin. Thanks so much for joining me on this explainer, and definitely keep questioning what's happening just beneath the surface.